This video lecture is going to address brain tumors. About a third of the brain tumors occur before the age of 5, and 75% of them before age 10. Half of them arise in the posterior fossa section of the brain. So half of them are affecting the cerebellum, the fourth ventricle, as well as the brainstem. When you think about this anatomically, you can predict what the signs and symptoms of these tumors are going to be. The frequency of the specific type of brain tumor that's going to be present will depend on the child's age. Astrocytomas account for 50% of brain tumors, and it can affect a lot of the brain, but these are nice, slow-growing tumors. A medulloblastoma affects the cerebellum, but these are rapid-growing, and these children will present with that altered gait. And it's one of those almost overnight things that the parents are saying they were fine, and then I've noticed over the past month that they're falling a little bit more, and now I'm noticing that they're walking with that broad-based gait. A glioma and the ependymoma, each of them account for about 10% of the tumors, but that glioma is affecting the brain stem. And here's a picture. You may want to put the video on pause just to see where these tumors are located. But you see on the cerebrum, you can have an astrocytoma affecting it, an ependymoma, an oligodendroglioma, and your PNET tumors. Those are neuroectodermal tumors. When we assess kids for brain tumors, their typical presentation is going to be complaining of a headache. They have vomiting, especially in the morning. They may have altered level of consciousness depending on the size this tumor has gotten to be by the time we diagnose. Our smaller children are going to have an increased bulging fontanelle, but usually these tumors are not affecting the babies. Because of the increased intracranial pressure, they're going to have a high-pitched cry. So all these signs and symptoms are related to the increase in the intracranial pressure because the head can only get to be so big. Other signs and symptoms are going to depend on where they are. So the coordination will be the cerebellum. Mental status, mood, personality, that's going to be more of your frontal lobe. And then we can have the vision affected. The cranial nerve changes, so they're going to have one side of the face that may not be moving because it's impacting the cranial nerves. And it can also affect endocrine function and respiratory pattern, especially if the brainstem is involved. They can end up having cranial nerve palsies, and they can have pyramidal tract signs that affects their gait, and they may have hemiparesis, so they're not moving one side, and they have a lot of ataxia, so they're unstable. Our diagnostics are just the same, the CT, MRI, PET scans, and then we'll do some blood work. And you can see here on this picture, this is an ependymoma that's affecting the fourth ventricle. So put the video on pause for a minute so that you can see the tumor. What I like about this picture is it reminds you where in the brain different things that we do occur. So the Broca's area, if that's affected by a tumor, this child's going to have difficulty speaking. If it's affecting the occipital lobe, it's going to compress on the nerves that affect our vision. The frontal lobe is going to be not only our personality, but also our speech. So this would be another time where you should put the video on hold just so you can read all of the areas in the brain as a reminder of the anatomy and what does what. When we treat brain tumors, they like to do surgery and resect it. Sometimes what they'll have to do is radiation ahead of time to try and shrink it so we can have minimal collateral damage. When you have a giant tumor and it's compressing on normal brain tissue, there's a chance that they're going to end up taking more brain tissue than they want. So that what they want to do is shrink it and then remove it. These children may end up becoming hydrocephalic as a result of the tumor and or the surgery. Preoperatively, your patient education, they're going to have their head shaved. let's tell them about that ahead of time. They may opt to shave it themselves so they can get used to it, and then they think they're cool because they did it. They're going to have facial edema, and their head is going to be wrapped. They're going to look like they're from the Middle East because they're going to be wearing a turban. Post-operatively, you're going to elevate the head of the bed. You're going to watch for continued signs of increased intracranial pressure. There's going to be some edema following the surgery, but the signs and symptoms of ICP should be resolving, not increasing. Assess the child for seizures, maintain their airway as always, and then watch for vomiting. We don't want these kids to vomit because that's going to increase the pressure in the brain. So you may be administering antiemetics prophylactically. And then chemotherapy, both conventional through their ports as well as intrathecal, may be used for some of the tumors. So like I said, the radiation may be used to debulk the tumor prior to surgical resection. And so they can do very guided gamma knife radiation therapy where it literally is radiating almost like it was a surgical procedure to get rid of the tumor. Unfortunately, brain tumors have long-term complications. These kids can end up with neurologic deficits that will last the rest of their life, and some of them are visible. You can see the child in the lower picture where she has no control over her eye. They can end up with learning disabilities, developmental delay, paralysis, seizures. They may end up being blind. The airways may be compromised. This isn't the usual case, but it depends on where that tumor is and how close to the brainstem it is. And then the hydrocephalus is an issue, so they're going to need a shunt, and they may end up being in a coma. So here's just a review of what we already learned the week we did neuro on how we can have hydrocephalus, insert a shunt, and it decreases the intracranial pressure. And this is our last part of the lecture, and I want you to put it on pause and see these kids. They've all had a brain tumor, and you can see some of them look like they're perfectly normal, while others, you can see the disability that they're going to have for the rest of their life. And this ends the lecture on pediatric brain tumors.